Hey, everyone. After grading the defensible documentation assignment, I just wanted to give you all a little bit of feedback and review some of the information with you just to make sure we're all on the same page. This was the document that I wanted you to read before doing the assignment on defensible documentation. And the idea is with the documentation, we are trying to show that the treatment that we did was medically necessary, that it addresses a physical impairment or functional limitation, and that's what we want to document, that we are working towards the functional limitations that were documented in the initial evaluation. We also want to show that the interventions we provide were skilled interventions versus non-skilled. So we want to clearly show why a licensed professional like a PT or a PTA was needed for the treatment versus having a caregiver do the treatment or having the patient exercising independently or something like that. So we're really trying to show why it's necessary to have a licensed professional performing this treatment. Does the treatment require the skills and judgment of a PT or a PTA in order to give this patient the treatment that they need? So our daily notes need to demonstrate why we are required to be there. Why are you required to be there and not somebody else, someone in the patient's family or another like another caregiver? Basically, you can think of it as the insurance company saying, why are we paying you for this? You can think of it that way. We want to show what progress the patient has made. We only want to use commonly accepted abbreviations, and when not sure, spell it out. I know I say that a lot, and I'm going to keep saying it because it's important. So interestingly enough, I was in a workshop that was hosted at Whatcom Community College for peripheral joint mobilizations for the PTA. The PT who was teaching it is a PTA program director from North Dakota, and he has come several times and done workshops for us in the past, and he hasn't been here since before COVID, and so it was nice to have him here. We usually have someone on staff participating in the workshop, and I was that person. And it was great because out of the 27 people that were taking the workshop, all but one graduated from the Whatcom PTA program, and I knew them all. They were all my former students. So it was wonderful. It was like a reunion. It was fun seeing everybody. But one of the things I asked everybody during one of the breaks is I said, who's doing electronic documentation in the clinic? Everybody raised their hand. Everybody. Nobody's doing written documentation anymore. We're doing it electronically. So there's no need to use excessive amounts of abbreviations. It is a lot easier to type it out, or if you're dictating, to say it out than it is to type out an abbreviation or do a symbol or something like that. So abbreviations are old school. We're moving on from that. It's the 21st century. So spell it out. So you want to be timely and complete in your documentation. You don't want to delay your documentation. A delay of several days is a red flag for calling the documentation into question, whether it's in a legal sense or in a reimbursement sense. The other thing that happens a lot, that I see a lot in the clinic these days, is I'm doing documentation and the patient is going to see the doctor later that day or the next day maybe. And the doctor is going to want to log in and see that note. So it's nice to have it done in a timely manner. You don't want to be behind on your documentation. There is a big push in the clinic these days for point of care documentation, meaning you're documenting as you're treating. Obviously, there are certain things that you're doing, like hands-on manual therapy or hands-on balance training, that do not lend themselves to immediate point of care documentation, but you want to do it as soon as possible after you performed the intervention, because well, number one, you'll forget stuff, and you just want to do things in a timely manner. Having having a charge posted the day after the treatment was done, that's a red flag as well, and your clinic might not get reimbursed for that treatment. So it's really important to be timely and complete. You want to have enough activity documented in your note to substantiate the amount of time billed for each code. So if you only did 5 minutes of ultrasound, well, you can't bill for that because it's under 8 minutes. But you want to document enough activity to substantiate the amount of time billed for each code. So when you are doing manual treatments or modalities treatment, setup time does count in the treatment time. So it's not just the time that the ultrasound was on, setup time, but you don't want to spend all of the time doing setup. You want to make sure that the interventions you provided relate to daily function for the patient and go back to the goals. So that's one of the reasons why we document the reason we did the intervention. So the good thing to remember is the daily note is not a patient report card. It is a record of the medical intervention that you directed and provided during the treatment that addresses the impairments and progresses the patients towards their functional goals. So it's not talking about what the patient did. And I know I've said this before, and I'm probably going to say it again. We're not documenting what the patient did. We are documenting what you did. So that is an important distinction for you to remember. So here, these are some examples of what you should use: terms that indicate skilled intervention, and red flags, terms that don't indicate skills. So you want to avoid using watched, like you watch the patient do exercise. Well, that's not very, that doesn't require skill. If you say analyze the patient's performance of the exercise, well, that's a little, there's some skill involved there. If you say practiced or patient participated in, you're saying what the patient did, not what you did. What were you doing while the patient participated in this? So you want to say you directed the patient in something. So an example that I see a lot of times in the clinic is aquatic therapy. Depending on the patient, a lot of times the patient's in the pool and you're out of the pool. So you're not just watching them do the exercise, or you're not going to say the patient participated in aquatic therapy. You're going to say that you directed the patient in aquatic therapy, and then you're going to specify what you did and why you did it, and what skilled intervention the patient needed, what direction they needed, what corrections they needed, that sort of thing. So helping's lovely, but it's not something that you're going to document. And we want to do instructed, taught, directed, reviewed and corrected. That's always a nice thing to say. So say that you instructed them in exercises last time, and this time you're going to review and correct. Say whether verbal cues or verbal instructions were needed for accurate performance of the exercises. Reminders are not really skilled therapy. Reminders are Post-it notes. So facilitated rather than led or reinforced. So if you said you led the patient through a certain exercises or certain activities, it's better to say you facilitated any activity or movement that the person is trying to do. That indicates skill, that facilitation. Measured, it's not necessary to say measured ankle range of motion. You can say you assessed their balance, or you assessed something, you assessed their gait quality. If you say measured ankle range of motion, if you just state the ankle range of motion, it's pretty obvious that you measured it. So you want to leave out obvious statements. And you also don't have to say things like treatment consisted of, or patient provided with, or ultrasound performed on. You don't have to, you can leave out those extraneous terms. So reviewed, you don't really want to say reviewed unless you say reviewed and modified home exercise program. So reviewed and corrected exercise form, something like that, but not just reviewed on its own. Modified, corrected, facilitated, those are all good words. Adapted, rather than fixed or revised. So sometimes a patient will come in after you instructed them in some exercises the time before, and I'll say, how did your home exercise program go? And they'll go, well, I couldn't really do this one. So then in my note, I'll say adapted exercise for patients' inability to get up and down from the floor. So we're going to do it on the bed, or we're going to do it on the, so I adapted the exercise. So sometimes I tell people that's my job, is if you can't do an exercise, if there's some barrier, my job is to help you problem solve around that barrier. So I'm going to document that I did that problem solving. Reinforced, not really skilled, but provided skilled feedback regarding something. That's an excellent way to say that. Patient performed, we don't really, in the treatment section, you don't want to start your sentence with the word patient. The only time you want to start the sentence with the word patient is in the subjective information, where you say the patient reported this. And as you might recall from my feedback from the last assignment, the last SOAP note assignment, you don't have to say patient stated this, patient stated that, patient reported this, patient did this. You only have to say it once. Say patient stated or patient reported, and then you can go to pronouns after that, or however you want to say it. But you don't have to keep saying patient said. You only have to say it once. So rather than saying the patient performed a certain exercise, you can say directed quad strengthening for stair negotiation, for example, or for sit to stand, or for transfers. See exercise log for details. We don't have exercise logs in the clinic where I work, but you could say the specific exercise. So you could say directed in long arc quads with 5-pound weights, 2 times 10 reps for, or 2 sets of 10 reps, if you want to say that. To strengthen for improved stair negotiation, you could say that. I don't like the word negotiation. That's just me. You can use it if you want, but you're going to be more specific about it, about what you did, not just what the patient did. Patient reports less pain. That's pretty vague, but you could say decreased pain to 3 out of 10 with ultrasound during today's treatment, or something like that. So you want to say it as it's a result of today's treatment, not just overall less pain. If you noted initially that the patient was moving really stiffly, you could say that they demonstrated improved movement after this intervention, something like that. But patient reports less pain, we want to quantify that a little bit. Patient tolerated session well. There are PTs in my clinic who say that on every note. I do not want you to say that on every note. So I don't want you to say that ever. And the reason I don't want you to say it is because it's too vague. What does that mean? They tolerated the session well. You could say patient was able to perform strengthening exercises with increased resistance today and no increased pain. That's nice. Reports no change. Reports no change, that's just lazy documentation. If the patient comes in, you say, hey, how are things going? And they go, oh, it's about the same as last week. Don't just leave it at that. You have to ask some probing questions and drill down to the information. Say, well, did you do your home exercise program? How did that go for you? Were there any exercises you had questions on? How's your pain level? Are you still walking with the cane, or have you gone to no cane? How are the stairs doing? You said that you don't have a railing on your stairs at home. Are you able to negotiate the stairs without a railing? There's the negotiate. So you have to dig for information sometimes. Saying patient reports no change is just lazy documentation. So don't be a lazy therapist. That's my note for the day, I'll say. So now I just want to go over the assignment, and the rewrite statement that I have here is not necessarily the only way to say it. It's just another way to say it that is a little more defensible, and the explanation. So in the assignment, we had the statement as it was, and we rewrote it to make it more defensible, and we said why the first statement wasn't acceptable, or whatever. So the first one, passive range of motion of the knee is getting better. Well, that is pretty vague. There's not enough detail. Better is not measurable. So if we just change it to passive range of motion, knee flexion extension is 0 to 95 degrees. You don't really have to say a lot, but 0 to 95 degrees is measurable. There's a lot of detail. We say which knee, that's nice, at the right knee. That it's passive, it's not active range of motion. That's all you need. Number 2, patient performed 10 reps of knee exercises. What was the therapist doing while the patient performed that? And what type of knee exercises are we talking about? So there's not enough detail, and the therapist role needs to be stated. You need to also state specific exercises and document that, what you did. So instructed patient in 10 reps of isometric quad sets with verbal and tactile cues for quad activation. Number 1, it demonstrates skilled therapy because we needed verbal and tactile cues to get quad activation. They wouldn't have been able to do that on their own. We were there instructing them in how to do it and giving them verbal and tactile cues. So again, it doesn't have to be a lot longer. It just has to include that detail and state the therapist's role and the exercises that were performed. So number 3, practiced walking in the hallway. That's lovely that they were practicing. Were they doing that between their therapy sessions? What happened? Who helped them? Did they need help? We don't know. There's not enough detail. There's nothing to demonstrate skilled intervention, and there's no measurable data. So if we change that, so anytime when we're walking with a patient, we're not practicing walking, we're doing gait training. So we're trying to teach them to be safer. We're trying to normalize their gait. We're trying to increase their independence. So those are all reasons for doing gait training. You could say gait training with front wheel walker, contact guard assist for balance, 2 times 50 feet with 1 minute standing rest break, O2 sats at 92% on 2 liters of oxygen while walking. The thing that is left out of this, and I didn't write this one, but the thing that's left out of it is the reason that we did it. And I would say to increase activity tolerance, or it depends on what their goals are. You could say to increase activity tolerance, to improve safety, to increase independence. All of those things would be reasons for doing gait training. So number 4, applied hot packs. Well, that's pretty vague. We don't know where we applied them, what we did it for, who did it. We don't know anything, except we know about hot packs. So moist heat to cervical spine to promote relaxation and improve cervical spine flexibility times 5 minutes. That's lovely. You could do that before you do your soft tissue mobilization. We provided rationale. We said where we applied the pack. So you could say, why is it needed? You could say it's to address pain, relax tissues. You have to state the area of the body, and what are the skilled services that you're providing here. So patient given strengthening exercises. Well, that's patient given. We don't really like that term. Very vague, not enough detail. We want to describe what type of strengthening exercises, including specific muscle groups. Instructed is a better term than given. So you could say patient instructed in home program of isometric strengthening for left quadriceps to improve VMO activation. So we said what exercises, why we're doing it, who instructed them. That's how we're going to do it. You could also say, you could say instructed patient in home. Don't start the sentence with patient. You could say instructed patient in home exercise, saying that you did it, basically. You're showing skilled intervention. So, okay, we had a lot of these where had not enough detail, not enough detail, not enough detail. Number 6, that is not a problem here. We have too much detail. So, well, the first part, patient received, we don't want to use that statement. And the way too much detail. Patient received ultrasound at these settings to right quadriceps VMO in 10 centimeter area, just slightly blah, blah, blah. Well, we all know where the VMO is. You don't have to specifically describe where the VMO is. That's pretty basic. And then moving ultrasound head slowly in a circular fashion. Anything that's a standard procedure, you don't need to describe how you did it, because that's how you perform ultrasound, is moving the ultrasound slowly in a circular fashion or a back and forth. But so it's just too much detail. It's sufficient to eliminate some of the details, and also all of that detail and no rationale was stated. So, you know, we wasted a lot of words and we didn't even have enough information. So you don't have to say patient received ultrasound or ultrasound applied to or anything. All you have to say is CUS or PUS if you did pulsed at 1.0 watts per centimeter squared, 1 megahertz to right quadriceps VMO, so specifically in that area, times 10 minutes to improve joint mobility and promote tissue healing. So if it had been pulsed ultrasound, it would have said POS and we would have stated the duty cycle. You don't have to state the duty cycle with continuous because it's always 100%. So you have to have enough detail, but not too much. So you never have to say, treatment began with, treatment consisted of, treatment followed by. You don't have to say any of that stuff. You can just list the things you did with the appropriate amount of detail. And we said the rationale for what we're doing. So number 7, reinforced use of ice at home. So reinforced doesn't really demonstrate skilled intervention, provided skilled feedback for appropriate use of ice at home for pain and edema management, says why we did it. You could also say instructed patient in appropriate use of ice at home for pain and edema management. That is another way to say it and demonstrate skilled intervention. So we just need to tighten that up a bit. So the last one, east-M to tibialis anterior, that's nice, but there's not enough detail and there's no rationale provided. So we need more detail. East-M to right tibialis anterior, say which one it is, we got 2 of them. For muscle reeducation to improve dorsiflexion. Pulse duration, 200 microseconds, frequency 50 pulses per second, 10 seconds on, 50 seconds off, ramp up and down 2 seconds, treatment time 10 minutes, and that equals 10 contractions of the tibialis anterior. So we need that amount of detail for muscle re-ed because we're saying why we did it, all of our parameters, how many contractions we did, and then the next time we know exactly what's going on. So hopefully this was a helpful exercise for you to kind of tell the difference between too much detail and not enough detail, and then using terminology and wording that is going to show skilled intervention, and not just what the patient did, but what we did and basically why we did it. So hopefully this is helpful. Let me know if you have any questions, and I'll talk to you soon.